This conversation is being hosted by Peer Research Associates, or PRAs, from the Thrive Project team at the BC Center for Excellence in HIV/AIDS, patients Magagula, Claudette Cardinal, Cheryl Linden, and Antonio Marante. Together, they're going to explore pathways and obstacles to home and community care for older adults living with HIV. So thanks all for joining us.
Hi. I'd just like to honor and thank the ISA, the whole conference 2022 for this opportunity to be here and to present on the traditional lands of the Mohawk, the people of this land of Montreal. There's such a great host, loving my time here. The weather's awesome, a little humidity, but it's okay. And I just like to start with our slideshow. We'll do introductions after, but we'll just get with the slideshow and then we'll get. I'd also like to acknowledge that we gratefully acknowledge that the Thrive team, we work, learn, and on the traditional unceded lands of the Coast Salish peoples, and that's the Musqueam, the Squamish, and the Tsleil-Waututh. And we honor the meeting here today on the Hauna Nation, the founding nation of the Haudenosaunee, and the people of the Longhouse Iroquois Confederacy, which is also comprised of the Seneca, Tuscarora, Cayuga, and Onondaga. I'm sorry if I'm pronouncing them wrong, but the lovely hosts of Montreal, us from BC. I'm not originally from BC, but we love it here, and we're so glad to present to people that have shown up. And next slide, please. We also would like to honor a dear colleague and friend that had passed away just recently. There was a memorial held for him, and we just want to honor Hesham Ali. And also in our Thrive study, we had one participant pass away. So we just want to take a moment with everyone here present, if we could have just a moment of silence and just take that time to reflect on people that you have worked with or have lost recently, and just honor them in a moment of silence. Thank you. Next slide. Thank you. Oh, that's you. And I'll pass it on to Antonio.
Hello, my name is Antonio. I am originally from Venezuela. This is a little story about me, about my community. So there are many areas that Latino living with HIV in Vancouver are facing. One of them is when they are newcomers, how to adapt to the health system in Canada is different. So creating many gaps inside us in order to understand the health system. As a Latino, we have a lot of connections to our religion, our family. We have a lot of superstition in our culture. And all of these areas create a lot of stigma. Stigma inside of us and stigma around us. So that stigma create a fear to disclose HIV. Recently, I am happy educating people living with HIV, Latinos living with HIV in Vancouver, and I just delivered the disclosure training and the HIV criminalization in Canada, so they need to know it. So, and the other piece is about internal stigma in the community, not as a HIV people, not as Latino, but as a person, LGBT community. LGBT community stigmatize people, and it's more about, we have suffered a lot of stigma and a lot of discrimination among other cultures, other communities, And we still, LGBT, discriminate people based on their body type, based on their preference, based on their thinking, based on sexual behaviors. So that's something that we need to improve. Next slide, please. And I will pass now. You need to unmute Patience. She is going to talk at this moment. Patient, you can talk.
Okay, thank you so much, Antonio. My name is Patience Makakula. I came to Canada as a government-assisted refugee, 2007. After arriving in Canada, I witnessed stigma and discrimination in healthcare and in my community as well. Stigma and discrimination pushed me to advocate for my community, especially refugees and immigrants. I'm a co-founder of Afro-Canadian and Positive Network of BC, serving refugees and immigrants living with HIV. As we all know, HIV, the stigma, in our community, there's a stigma attached to HIV, which has been ongoing and it has not been addressed till today. We still have people are dying in our community of AIDS. And also in our African community, living with HIV is a curse, and we are labeled by your friends, by your relatives, and also by the entire community. Loneliness is huge because of that stigma. People tend to hide and people tend to shun away from the services. And it's challenged, especially to people who are living with HIV, and at times they stop accessing treatment and also they stop engaging in the community. And also taboos in our African culture, they are still believed, and they're worsening shame and fears. And most of our seniors, as they grow old, our older adults living with HIV, all of them, they tend to go back to Africa to avoid being sent to care homes. And most of our seniors are dying because they cannot access care and treatment and programs in the community because of shame. And absence of family members in Canada worsens the complexity. Majority of these seniors, they came here and sponsored by their kids, and they have challenges of loneliness. And loneliness, as we all know, is a killer disease. Thank you so much. Next slide. Next slide, please.
Hello, my name is Wapokuni. I'm from the Musqueam clan from Treaty 6 territory, originally from Alberta. I reside in this Squamish, Tsleil-Waututh, and the Musqueam peoples in British Columbia. Well, I call it beautiful country. And this is my interpretation of the SWOT analysis, but from an Indigenous lens, and how I will interpret this to you. So my heart, everything comes from our heart. And the strengths, they're known. The strengths are, think of your arteries in your heart. That's your strength. That's your blood pumping to all the arteries that keep us functioning. And then in the body, with living with HIV and aging, all the comorbidities that we live with, that's the body telling you of your weaknesses. And then you can overcome them when you put your mind, then the opportunities will come. Your spirit knows the threats. I don't think is threats as a threat. Those are warning signs to get these four elements, your heart, body, mind, and spirit, as one. Then you'll be in balance. And then these things won't matter, because these are just indicators telling you what your strengths are in your heart, your weaknesses in your body, opportunities. You put your mind out there, that thought, that vision, And the threats, they're not threats, they're just warning signs telling you, okay, maybe I shouldn't go for this or that because there's something, you've got that gut intent that tells you don't go there, right? For me as an Indigenous person living with HIV, I posed a question to the audience just at a Horizons conference. Nobody could answer that. There is no place for individuals like us living with HIV that are aging, because we can't afford those posh living places, right? That normal people would go, right? That have funds and retirement and have that access. So we stood up as the team. We're all diverse of different nations. And that's what I asked the audience. For me and my custom, everybody comes when there's a family member and they're about, that last rites and stuff like that. The whole family comes. So how am I going to be accommodated when I go into a home? They're not going to be accepted of me. One, they're going to stigmatize me because living with HIV, they see that on your chart. Then it comes down to, can I afford that place? And then because we look healthy with the medications and everything, they'll just, the racism is there, the stigma is there, isolation. A lot of our participants mentioned that about the isolation, especially with COVID and how we adapted to doing the over the phone, right? We did in person and all that. So I'd just like to end that with that. Thank you very much. Next slide. Next slide. Yeah.
Okay, my pleasure to talk about another PR researcher working with us. Cheryl is the wisdom, the wiser knowledge of our research project. It's through her personal experience living with HIV and receiving home support. She was the catalyst of the community-based Thrive research project, a home community care-based studies in BC. So Cheryl was giving us directions, guidance to how to approach the questions, how to design the question for our participants. And she was like, the phase one of this project was made on her. So we were involved in the second phase. So that's that story about our other research associate who is not here with us. Next slide, please. So this is the global numbers about HIV. How is the all people living with HIV? How many of them are on treatment? 20.8 millions. In Canada, we have fortunately 62,000 people living with HIV. And this next slide, please. So for in BC, the older adult living with HIV represents 64.5% of all people, of all population living with HIV. And as we get older, we require more assistance from health services, particularly for home and community care services. Home and community care services are home support that you receive in your house, community nursing when you require more services from a nurse, for instance, when you are rehabilitating from a surgery, community rehabilitation when you need more care, assisted living, and long-term care. So these are the whole services we ask our participants to their experience in receiving those services. Next slide, please. So the cascade of services in the top says number of cascade of services for people living with HIV in BC. We couldn't find the way other provinces has, because every province, as you see, the health services in Canada, it's a responsibility from the province, not the federal government. And every province report numbers in different ways. So we couldn't find these topics related to other provinces. So in BC, the number of diagnosed people, 6,859, and it represents 100%. The link of care, number of their link of care, 95.2% are in care. 76% are in point 4 are retaining care. On treatment, adherent and suppress. So the goal is to have each one of these bars in 95%. We need to continue working on. I was checking all the numbers for when we added all people living with HIV in BC, and still is not 95% each one. So some of them are 95, some of them are not. Next slide, please. Okay, I will pass now to patients. Patient, that's your turn now.
Thank you so much, Antonio. In our research study in BC, as my colleagues have mentioned, we have 59%, 16.27 had 2 or more comorbidities. And also the 3 most common comorbidities were chronic obstructive pulmonary disease, COPD, and also 10 to 37% arthritis, 7.26%, and hepatitis C. So we had 4.19%. And also stigmatization and discrimination and social isolation, highlighting the need for cultural safe HCC care. As we all know, we talk about stigma at all times and discrimination, and mostly it's in healthcare. Obstacles and pathways occur at 4 junctures. Number 1, before referral.
Hello.
Hello.
My 2 dots.
Hello.
Hello.
I can
My
hear
turn.
you.
My turn, patients.
Oh, sorry about that.
No worries. Thank
Sorry.
you. Thank you. Next slide. No, I'm just saying, no, I'm still on this one. Sorry.
Yes, sorry about
No worries, sister. Alrighty. So for the next 2 bullets, obstacles and pathways, I just want to give a little insight to those 2 words. Language is very important, and I was the one that made that change, and I applaud Thrive for following through with change in language. Before it was called barriers and facilitators, right? And for an Indigenous person living with HIV, when I hear barriers, I'm like going, I drop the mic and go, I don't need to go there. I don't need to access any services. And then for facilitators, it's like all these people in my business, right? So then I expressed this to the team and I said, can we use some more softer language, more open, right? And that's where I changed from barriers to obstacles and facilitators to pathways. So I just want to let you know, and that's in a manuscript. So that's how powerful individuals living with HIV that don't think that they have that voice can do big things, right? So we had 4 junctures. We had the before referral, during the referral process, at the assessment level, and while receiving services. And resilience came up a lot beyond the individual responsibility, including the interpersonal levels, neighborhood, community, and policy and epidemic level pathways. And when I speak about the neighborhood and community, it goes even into another level of community. And here, you here sitting in this audience is that community, right? People living with HIV, that's where we step up in the community and help all these other people with these kind of services they're lacking. Next slide.
So we are going to have a few questions that you think about. We are going to have the first question is, how in your region or your country take care of older adults living with HIV? And we want that you write down in the sticky notes. Claudette will give it to you, or if you want to speak out, and I will write here how you feel comfortable. We want to hear from you because we have our own perspective, our own research in BC, and we want to know from your country or your region how they treat older adults living with HIV.
Just a heads up, if and when you come up here to stick things on these chart papers, you will be caught on the camera. So if you have a problem with that, I just want to let you know. Okay.
We can take the sticky notes if you, no problem. Okay. Okay. Do you want to hear, or you want to, we want to talk, or you want to write down in the paper? What do you want?
So I can't really speak for everyone else. We are in the same country, very similar to Canada. The provinces are the ones that handle the medical care. In the United States, we have the federal, but we also have the states that can affect how the federal. So we also have the states that can affect whatever federal plans there are. For instance, we do have an Affordable Care Act, which is similar to a national health care plan, but the states don't have to necessarily implement the entire thing. So every state could be different. So it's more of a patchwork quilt. And because of that patchwork quilt, you have folks who can get a plethora of services in one state, but then can move to another state, and then they don't get anywhere near.
So that would be an obstacle for you.
Yeah. And I like that you use the obstacle as opposed to challenges. Obstacles are more like something you can try to traverse, go around and under. And yeah, exactly. And a barrier, a barrier means don't go there. You're not supposed to go past that line.
You can say it's from state to state is different.
Yeah, it's a different rules, regulations in terms of access per state. How much money you get from your Medicaid, how much money you get from Social Security, depends on the states as well. So it makes it very difficult for people to try to manage their care if they go from state to state.
If we think about how the services they receive, what do you say they know that you know at service they receive? Like services in your home?
Received as someone older living with HIV, an older.
In the state of Pennsylvania, Philadelphia, we are doing, I just wrote it down so I can say it. For our HIV Planning Council work group, we have put in our directives to identify programs for people aging with HIV. So, in the areas that we want to increase in our allocations budget is mental health, housing, and food banks. And so we feel that we've just had a meeting on Wednesday and increased the amounts because HRSA has given us a 5% increase in our allocation budget. And so our focus was to put that for people living with HIV and who are AIDS.
I completely understand that. I live in Minnesota. I was a member of the Planning Council in Minnesota, so we were allocating all these services, primary care services, supportive services.
Those Marante Planning Councils, Marante program, that helps offset some of the differences that the states create when it comes to access. If a state has a problem, then the Rhode Island Planning Council can build a bridge to help create a pathway for people, in spite of what the state has in place that creates a challenge or a barrier or anything along those lines, obstacles.
It's Patience here. I would like to add on to what my colleagues and the rest of the people have mentioned.
Yes,
In
go
my-
ahead.
Hello, can
Yes,
you hear
go
me?
ahead. Yes, we can.
Okay, I would like to contribute on the African community. So African community, we have challenges, so many challenges. Stigma, one of them, which affects almost every community. We have our seniors, our older adults living with HIV. We mentioned before that our older adults living with HIV, they're impacted by so many factors, of which one of them is isolation and also stigma itself. Most of them, they cannot even access care. They cannot even get out of their houses to access services. And we lost a number of our seniors because of stigma and discrimination, because of shame, because of misinformation. Misinformation, we like around the past years, like 4 years ago, we talked at length about isolation and also about misinformation. We are working closely now with faith-based organizations because there is a belief that pastors and traditional healers, they can cure HIV, which is not true. And most of our seniors, because of language barrier, they believe in all those statements which are said, and that's when they stop accessing care because of that misinformation from the faith-based organizations, of which they are told not to take medication and believe in the prayers and also traditional medicine. And also stereotypes in our African community. And the reason why most of our seniors, they tend to go back to Africa is because of extended family. Here in Canada, most of them, they came here, they're alone, they don't have family. As you all know, family is medicine. Without family, there's no way you can cope with life. So going back to Africa is a solution for our seniors, for our older adults living with HIV. I think it happens to most communities as well. Thank you.
Okay, with my 501c, my nonprofit, we work with what we're finding trouble with is housing. So I try to provide affordable housing for them. Not only that, but also try to link them to care, especially when they fell out of care. Some people that are HIV positive that may pull me to the side when they hear me share my story. Some people don't know, they really don't even know about the HIV status. So it's like linking them to care, trying to find support groups for them, trying to find housing. We do food referrals. Some of them don't know anything about the food referrals that's in the community. Some don't know about the support groups that are there. So I basically try to speak on a lot of that. And when they pull me to the side and ask me about some of the things that I'm doing, I try to share with them on what's in the community, what they can use on their behalf, ask for to try to make their life a little bit more livable, I can say. Because I've run into people where they've been 20 plus years HIV positive and don't know anything about what's going on in the community, ask for, they can get support, not even places that they can go that have HOPA funds that can help them pay for like utilities when they're behind, or, you know, may need help with their rent or mortgage or any of that. Some of them just don't know. So what they've been going to a doctor that's probably been prescribing their medication, but they may not have reached out for help. And then the doctor may not have been asking them questions about what is it that you need. So when you're not being asked those questions and you're not speaking up for yourself, then that's a barrier, not a barrier, but that's an obstacle right there that's in the way for them. So I try my best to, when I do speak about my status, I also speak about the things that I'm doing in the community so that, and I see it now so that they can pull me to the side and ask me, because you still have people that has not revealed to family members that they're HIV positive. You know, they still hiding their medication so that people don't see it, or no one asks them what they're taking that medicine for. And it's still kind of sad, you know. So when they call me, we talk. I have some that may try to come out to support groups, but still with the stigma, still scared of people them knowing. It depends on where they work at, where they hang out at. They're not wanting no one to know that they're HIV positive because the stigma is so thick. So yeah.
One of the things that we are doing in the US that we should have mentioned was we are all part of a national organization called the National HIV Aging and Advocacy Network, which is an organization that was developed and created by individuals who are HIV positive, over 50, and who has been long-term survivors. That also includes our verticals, who are also our long-term survivors. And we are working for advocacy and policy for individuals who are HIV positive and over 50 long-term survivors.
We just want to stress with the part about the verticals, because the verticals are those. I am a person who acquired HIV through sexual practice, but the vertical was born. Young people who receive, HIV through transmission from their mothers or as when they were born, and they've been living with HIV all their life, and so they've gone through the pediatrics, and now as they grow up in AIDS and get into becoming adult medicine, they don't find out that they're HIV positive until usually in their teenage years. So if you can understand the trauma I felt as an adult, who worked in HIV and acquired HIV, but those children that were born with HIV and didn't find out they were HIV until they were in their teens or 20s, that's a culture shock. And that's a way, and they're like 10 years behind me to start adherence treatment and all of that. And because then the parent transfers the responsibility to a young person who may not be equipped to handle the magnitude of finding out that you're HIV positive. And I know there wasn't no counseling. There wasn't no counseling for me in 1993. I had to walk out the door, told me I was going to die in 6 months. I told them, "You a lie." And then I started living my life a healthy way, and by taking my medicine. And I was, I wasn't the best patient. I was not, a non-attentive patient. But today I can stay here and say I am undetectable but I got the support that transferred me from a non-adherent patient to a patient that takes their medicine regularly. And so education is also something that prevention and education still needs to be done, because a lot of us, like Janice was saying, she's from the South of America. So in the South, we have not put the resources in America down in the South. And most of the cases of people dying today or becoming newly infected is in the South. And so these three are from the South. I'm from the North, and up in North in New York and Philadelphia and Washington, we've been working.
Thank you very much. Very rich, this conversation. So we are talking about here
Can I please add one last sentence?
Yes.
Like for all of us who are open with our status, I think this is the time when we have such conferences, International AIDS Conference, that's when we need our voices to be heard. Let's come together and collaborate with our youth, with our young adults, because for seniors, they don't have that voice because of stigma and shame. Let's all come together and have one voice and talk about solutions to all these problems. What are we doing? We want all these services to be done in an appropriate cultural way. We all have a culture. We want to age in our homes. In care homes, people are discriminated. That's when we see a number of people dying because they don't have a voice. They're discriminated in their everyday life. Can we use this opportunity to come together, all of us, and come up with a solution? By end of the day, we also have to advocate for funding. There's nothing we can do without funding. I think we also, there's a what do you call this? We are all fighting for funding, especially here in Canada. We want that funding back. Our funding was taken away 2016 because they say we are living longer. There's no one who's living longer without services, without programs in our community. Thank you.
Thank you, Patience. So I want just to move to this question. What are the strength-based pathways? So we'll talk about obstacles. We talk about how the region treat your older adult living with HIV. But what do you say are the strengths in your services your older adults receive?
Sorry about that. One of the strengths I think is the focus on being people driven, the focus on being people with HIV driven. Through the Ryan White program, through MIPA, meaningful involvement of people with HIV, taking to heart what the Denver principles put out there in 1983. All of those put together create a pathway. I can write it. All of them create a pathway for people with HIV to share what we think is going to be best for us. Whenever you share whatever's new coming down the pipeline, we can share with what works, what doesn't, how to make it work if it's not working, and so on. It's that old disability saying, nothing about us without us is for us. It's exactly it, essentially. If you're going to do something that's meant to help me, then talk to me so I can let you know how it can help me in an even better way than you're even thinking.
I want to share a story. This is a news that we receive from the CBC, the news broadcast in Canada. Denmark has for older adults living with HIV, older adults in general, they don't talk about HIV. Older adults, senior people, they receive at least 10 services per day in Denmark. 10 services, so 10 times they can call for any service and they receive the service that day. And the following day, they receive another 10 services. In Canada, we have only one service per week. That's the difference that we can have from Denmark. They say, well, Denmark is a very small country, but we have a very big country and we need to behave for big country.
Just to clarify, when you say services per day, you mean like visits from a home care practitioner. So they can have 10 visits a day to help with getting dressed, get out of bed, making meals, etc. Yeah, in Canada, we can sometimes only have one per week. So you get basically one bath or shower. That's it.
That's a strength from Denmark. That's the weaknesses for us. So I want to hear your strengths.
I mean, with healthcare in America, we have the difference between health equity and we have the difference between people who have access to health. And health equity, I mostly mean brown and black people do not get, because of our racism, because of our problems in our country, we're sort of on the lower. There's the haves and the have-nots. And we represent the have-nots here. And one of the ways about getting any kind of change is to protest. And so I'm from the original group of ACT UP. And I know when we didn't have ACT UP, Fight Back, Fight AIDS. When we had AZT, we was like, nope. We went to you know, FDA. And so we have to push. We really have to push. And you know, I'm 67 now, so I'm a little tired of pushing, but with my passion, I can't quit. I still got to push because I want the injectables. And Kavanaugh is fine, but for us that been on retrovirals for years, we can't take Kavanaugh. My doctor can't give me a Cabenuta, whatever that one is. Can't give me an injection. Talking about I gotta wait until the next round of injectables come out. When is that gonna be? Am I gonna still be here? I've been waiting ever since that doctor told me I had 6 months to live. For 40 something years, I've been waiting, and no more waiting. And so we seen protests change. We seen protests change police brutality with the George Floyd. We seen it change with the civil rights, and we're gonna see it change with the same thing about women and their right to choose. That's all I got to say.
I think for me, my strength comes from when I first got diagnosed 16 years ago, and we was at one of the health departments, not yours, Jeff. Was at one of the health departments, and my case managers changed. My case managers didn't have the information to give me when I was diagnosed, and I was diagnosed at the health department. So I think for me to go on the quest to find out all the information I can, and like I still do, so that the next people or the next person that comes behind me won't have to go through the ridicule and stuff that I went through, ask for to find out what services, like I say, linked up in services, medical doctors. Like my doctor now, I've been with my doctor for 12 years. And I happen to be in certain places like this, and I kept seeing him speak, and I kept showing up and found out where his clinic was. So I've been following him for 12 years. So, you know, making sure that they're medication compliant, because you have some clients. I have a client, she said she have a happy day. Her happy day is she take all her HIV meds this day, but the next day she don't. So she's done that long enough to where they've had to cut off her foot, but she had other illnesses too. So with her just taking her medication on like Monday, she don't take any on Tuesday, even if that's her diabetes medicine, her high blood pressure medicine, or her cholesterol medicine. She take everything one day, the next day she don't. So, you know, and it's up to me to get the information and put it out in the community, you know, with them. You know, that's my strive and that's my strength. And my other strength is that seeing them when they start thriving, seeing them when they start taking their medication, seeing them when they get better, because I've seen them at their worst. And when I say, if I have to call you every day to remind you to take your medication, then that's what I'm gonna do. You'll have to tell me not to call you no more. You know what I'm saying? So that's my strength. If as long as I keep providing information to the community and the people I serve, I mean, that's like lifting me up on a high.
All right, thank you very much. So we are moving now to the end of the presentation, and we asking you 3 questions. How does your region manage HIV? The last slide, it's the last. Yes, the next one. Obstacles, and then the next one is the strength pathway. So the next one is so
when we're older adults living with HIV are supported by their pathways along their journey, and each individual's journey is unique to that person. And their journey to access home and community care, they can thrive and age with dignity. And next slide. And there's our contacts. If you want us to take a Snapchat or a picture, you can get a hold of us. And I'd like to say thank you all for being here.
we are going to take your notes as part of our discussions in our team. Thank you very much.
So thank you very, very much, both. Yeah, okay.
You just heard from the 2022 Car Campfire Award recipients. Us Little Thrive team that presented to you today won that award for community-based research. So thank you.
Well deserved. And thank you very much, both of you, for being here, and Patience for joining us from home. And Rana, who's the coordinator of the project. And thank you so much, Thrive Team. We really appreciate you being here in the Silver Zone.
Thank you so much for having us. It was a pleasure having this opportunity presenting today. Thank you.
Thank you.